Our first talk is a very interesting talk. Is PCOS an inflammatory process? I would request Dr. Madhuri Patil to please come up and take the dais.
Good morning, everybody. Can I have my slides, please? So in the last 2 days, you all have heard a lot wherein it was spoken that probably PCOS is an inflammatory process. So let us see, why do we call PCOS an inflammatory process? So inflammation is the result of an innate immune response to infection, injury, or any other irritation. And the evidences that support the presence of chronic low-grade inflammation in PCOS is emerging. And this is because we know that inflammation is associated with other prominent aspects of PCOS like obesity, insulin resistance, and cardiovascular risk. It's a key feature of endothelial dysfunction and atherosclerosis, and the increased visceral adiposity across all categories of BMI. So even if you have a low BMI, usually in a PCOS woman, the visceral adiposity is more. It exerts its effects on the insulin resistance, hyperglycemia, dyslipidemia in a paracrine and endocrine manner via secretion of number of molecules, and some of these molecules are markers of inflammation. So the PCOS woman is more prone to inflammation is basically because of adiposity, and adipose tissue acts as an endocrine organ which secretes chemokines and free fatty acids, which are important to the immune cell infiltration and initiation of inflammatory process. And this initial inflammatory response is an important mediator of obesity-associated systemic inflammation, and the adipocyte hypertrophy is associated with insulin resistance and inflammation. And thus, we can say that obesity is associated with chronic low-grade inflammation and causes most metabolic complications. So, visceral obesity is pro-inflammatory with abnormal levels of inflammatory markers without clustering of the cardiometabolic risk factors. It also shows intriguing association with low-grade infections, and the effect is seen also on the non-adipose tissue, the endometrium, and the ovarian follicle. In the non-adipose tissue, the free fatty acids accumulate, which is characteristic of the metabolic diseases. And accumulation of intracellular lipid leads to lipotoxicity with oxidative stress, endoplasmic reticulum stress, and ultimately apoptosis. Lipotoxicity in numerous cell types leads to obesity-related diseases such as heart disease as well as type 2 diabetes. If you look at the effect on endometrium, it has been observed that there are elevated circulating serum free fatty acids levels as well as C-reactive protein. And this then results in altered gene expression in the endometrium, which is important to the activation of immune system and inflammation. And this then results in increased production of pro-inflammatory mediators and enhanced immune cell migration with compromised decidualization and excessive inflammation, which may impair implantation and also predispose to endometrial cancer. So if you look at the effects of lipotoxicity in ovarian follicles, there is increase in the C-reactive protein as well as TNF-alpha in the ovarian follicular fluid, which results in activation of the estradiol receptor stress pathways, results in mitochondrial dysfunction, and increased apoptosis in cells of the developing ovarian follicle. And the lipid accumulation happens not only in the granulosa cells and the follicular fluid, but also in the cumulus cells as well as oocytes. Thus, total body fat and visceral fat independently have a major impact on the serum levels of inflammatory mediators as well as WBC. And this obesity-induced inflammation results in cascade of events leading to insulin resistance, dyslipidemia, increased ovarian androgen production, and reproductive dysfunction with increased metabolic dysfunction. So it's not only the obese, but in non-obese also we see inflammation, but the pathway is probably different. Here, the glucose and saturated fatty acids induce pro-inflammatory phenotype in the mononuclear cells and foster dyslipidemia, and this is independent of insulin resistance and obesity. So what are the manifestations? So we could have changes in the C-reactive protein, pro-inflammatory cytokines and chemokines, various markers of endothelial inflammation, white blood cells, oxidative stress, advanced glycation end products, as well as we can see that there are certain infections related to PCOS. So we know that C-reactive protein is an acute phase reactant produced by hepatocytes under stimulatory control of pro-inflammatory cytokines interleukin-6 and TNF-alpha, and the mediators of inflammatory process, and these induce endothelial dysfunction and promote monocyte chemoattractant protein 1 mediated chemotaxis with elevated levels are seen and are predictors of cardiovascular risk and events. It has been observed that even a modest elevation of C-reactive protein is associated with increased cardiovascular risk, and if it is between 1 to 3 nanograms milligrams per liter, there is moderate risk, but if it is more than 3 milligrams per liter, then the risk significantly increases. This was a meta-analysis which evaluated 31 trials, of which included 2,360 PCOS patients, and it was concluded that the CRP in PCOS women is 96% greater, and when they looked at the and matched it for the BMI, they found that CRP in PCOS women was then almost 102% higher as compared to the controls. There was another study which looked at the adipose acylation stimulating protein complement C3 and CRP, and they found that it is elevated in all PCOS women, and this is regardless of the BMI, and this very closely correlated with the lipid parameters, which increase the risk of dyslipidemia as well as cardiovascular events. There was also a relationship seen between follistatin levels, which were high and they were associated with increased CRP, which related to the chronic low-grade inflammatory status, and the association between follistatin and CRP levels was independent of obesity, insulin resistance, and free androgen index. Coming to the pro-inflammatory cytokines and chemokines, we know that PCOS is associated with increased levels of interleukin 18, MCP1, MIP1A, which induce chronic inflammatory process, and it has been seen that interleukin 18 is closely related to insulin resistance and metabolic syndrome, and the MCP1 is again plays a role in development of atherosclerosis, whereas MIP1 is a chemokine and it is involved in recruitment and activation of leukocytes. Thus, evaluation of these chemokines and cytokines are predictors of long-term cardiovascular events as well as mortality. The other most important is the adiponectin, which is a protein hormone and is involved in the regulating the glucose levels as well as the fatty acid breakdown. It exhibits a protective activity in several inflammatory diseases, including atherosclerosis, cardiovascular disease, and insulin resistance, and it has direct action on inflammatory cells, suppressing the ROS, stimulating expression of anti-inflammatory interleukin 10 cytokine, suppresses the NF-K beta inflammatory signaling pathways, and also results in downregulation of inflammatory response to TNF alpha. So what happens in PCOS women? We can see that they have large adipocyte volume and lower adiponectin levels as compared to the controls, and this low adiponectin level is which is adiponectin, which is protective against cardiovascular disease, is not there, and therefore there is loss of protection, and it results in insulin resistance, diabetes mellitus, and cardiovascular disease. Coming to endothelial inflammation, we know that there are many elevated markers, and basically there is also resistance to insulin-induced vasodilation, and these are the various markers which will suggest that there is endothelial inflammation. They play a key role in the cardiovascular disease and in particular in the development of atherosclerotic plaques as well as hypertension. Again, insulin resistance has an important role in inflammatory pathways, and it has been seen that acute hyperglycemia causes increase in the generation of ROS by peripheral blood leukocytes and induces leukocyte endothelium interaction. There are changes in the mitochondrial membrane potential and activation of pro-inflammatory transcription factors, the nuclear factor B, and also it also increases the TNF and endothelial dysfunction. It has a negative impact on the mitochondrial endothelial function and oxidative metabolism, and it is associated again with increased cardiovascular risk. So it has also been seen that there is a significant increase in the WBC count in the PCOS women as compared to the controls. And this elevation of lymphocytes and monocytes correlates with the insulin resistance and can be correlated with the HOMA. And elevation of WBC are associated with multiple cardiovascular risk factors, including increased BMI, adverse lipid profile, as well as periodontal disease. It was also seen that the mononuclear cells modulate the inflammatory response, and this is because the dietary trigger by glucose, insulin resistance, and hypoandrogenemia induce oxidative stress to stimulate an inflammatory response for mononuclear cells independent of obesity, and these MNC-derived macrophages also promote adipocyte cytokine production in a paracrine fashion and cause local inflammatory response that stimulates even androgen production, and therefore again we will see that these women have increased incidence of an ovulation. The other important factor is oxidative stress, and the lipid peroxidation as well as protein carbonyl content was seen to be significantly increased in women with PCOS, and this increase correlated positively with the BMI, insulin levels, as well as the blood pressure, and therefore again they are markers of metabolic syndrome. There was reduced total antioxidant status, glutathione and haptoglobulin, a protein with an antioxidant property, and women with PCOS also had increased susceptibility of the DNA, and this susceptibility correlates with the free testosterone level. The ROS generation by mononuclear cells in response to hyperglycemia is greater in PCOS women as compared to the control subjects, and basically this then induces a vicious cycle between inflammation, ROS, oxidative stress, and again inflammation. Coming to the advanced glycation end products, which are elevated in PCOS women, and these levels correlate with the level of AMH, presence of PCOS, as well as an ovulation. And they basically act on the signal transmitting receptors, leading to induction of oxidative stress, and by acting both directly and through RAGE promotes development and progression of cardiovascular disease. There is greater elevation seen in women who have NIH-defined PCOS irrespective of the ovarian morphology, and intermittent levels are seen in women who have hypoandrogenic ovulatory status and also in anovulatory normoandrogenic women. These levels are basically normal in all women who have isolated hypoandrogenemia, isolated polycystic ovarian morphology, and isolated anovulation, and therefore probably this could tell us whether the woman really has polycystic ovarian syndrome or not. And the last part which I would discuss is the presence of infections. Though there's not a lot of data on correlation of infection with PCOS, but a possible association was seen between chlamydia species, Helicobacter pylori, as well as periodontal diseases like gingivitis. It was seen that chlamydia pneumonia seropositivity correlates with the presence of atherosclerosis and acute myocardial infarction, and that with Helicobacter pylori is associated with arterial stiffness and unstable angina, and pathogens which are involved in periodontal disease is linked to inflammation as well as cardiovascular risk. It was also seen that there are enhanced inflammatory transcriptomes in the granulosa cell of women with PCOS, and this is determined by an increased CD45 mRNA and protein, which is related in part to PCOS adiposity. There were also elevated expressions as implications on the oocyte quality and embryo development, as well as early corpus luteal formation and the risk of ovarian hyperstimulation syndrome in response to gonadotrophin stimulation. We also have heard yesterday in the panel, as well as Dr. Kathleen Hogarth has clearly said that the incidence of anxiety and depression is very high in women who have PCOS, and this results in increased activity of the immune system with increased pro-inflammatory markers and therefore resulting in increased metabolic syndrome. There is also an altered function in the HPA axis with altered morning and night pulsatility of ACTH and cortisol, exaggerated ACTH and cortisol response to exogenous CRH, and exaggerated cortisol response to cognitive stress. And it was seen that when you look at the various interventions which are given for stress and the attempts made in elevating the emotional disturbances improves the insulin resistance, the HPA axis functioning, obesity and hyperandrogenism, and also results in decrease in the inflammation in the PCOS women. So I would conclude by saying that PCOS is an inflammatory process, and it has an inflammatory state in the metabolic syndrome and is represented by elevated concentrations of variety of inflammatory regulators such as C-reactive protein, TNF alpha, resistant interleukin 6, 8, visafatin as well as adiponectin. And if you can see that there is an important link between a total body fat as well as visceral obesity, insulin resistance with the lifestyle management, low grade which results in chronic low grade inflammation, and this can then affect the circulating sex hormones resulting in poor oocyte quality as well as impaired ovulation. So it is the increased abdominal adiposity which contributes to the inflammatory load in PCOS women, which can seen in both obese as well as lean PCOS, and its development may be controlled by severity of hypoandrogenism seen in the PCOS women. And I thank you all for a patient here.